Hello, I will tell you about open comminuted tibia and fibula fracture. This is just one case, but there are many tips. The patient came to our hospital. He has previous calcaneal fracture. In this case, this is industrial injury. You can see the simple X-ray. As you can see, the spike tip is sharp tip is open wound over there. And this is CT scan. You can see the severe comminuted fibula and tibia fracture like this. This spike is open site. This is posterior malleola. This is anterior part of tibia. This is skin open site. You can see the spike and the sharp bone was exposed like this. If you choose open approach, it can induce the necrosis and infection. So my principles: minimal incision, minimal manipulation, and the most important one is alignment is the first and primary. And so I usually choose the several stages and should inform to patients about the necessity of the several stages of operation. At least I usually tell my patients in like this case like this, at least 5 times. Initial, if necrosis, if infection, if non-union, if something, final remove or implant. So it's more than 5 times. If less than informed stages, then the patient will be happy. This is very important to give the trust to the patient. About wound, should inform about frequent and meticulous dressing and maintenance moisture of wound. If wound is dry, then the wound can be changed into crust and defect of skin. And do not do direct closure, stepwise, and gradual wound closure is required. First operation, the most important is alignment. The skin cannot be opened except open wound, and it will be difficult to open the fracture with the other incision, and it will be difficult to align the fracture later due to callus. So in the first operation you should align and make shape. So no further incision. Do your best and my best to align the fracture in this first operation. In the first surgery, efforts should be made to restore the shape as much as possible with a minimal incision. You can see the fibula and tibia. If you incise the anterior skin, it can be disastrous. After first operation, I apply the external fixation, and you can see the skin is opened like this, and this is fixation with Steinmann pin. No further incision. And this is lateral side. You can see the interval over there. I use the MIPO technique, and you can see the small incision to fix the anterior tibia part with a cannulated screw. This is X-ray. This is first operation. You can see the external fixator and the fibula MIPO technique, and distal tibia with cannulated screw, and this is Steinmann pin to align the. This is AP view. This is side view. Usually, you in the first operation, you should everything You should do everything. Not, also, I will tell you about the medial incision like this. No tension, no tie, just shoelace sutures. It can be gradually closed as the status of wound. Like this, you can see one. That one. Maintenance of moisture by soaked Vaseline gauze. Seal the wound to keep the moisture skin from dry. This is the middle side. Also this one. And second operation, after subsidence of swelling, 2 weeks later from first, to make reduction of posterior malleolar fracture like this. It was really big fragment, but initial surgery I could not do that because of wound and the swollen state. So I decided to perform posterior malleolar fracture when the swelling subsided and the skin condition permitted. Posterior medial approach, I choose that one. You can see this one. This is initial open wound like this. This is lateral side wound. Is at first operation. You saw this before. After second operation, you can see the X-ray. This is plate for posterior malleolar region. I used the recon plate and the preventing over there, and the leg screw over here. This screw is a leg screw to compress the posterior fragment. After first operation, you can see the medial side wound is really good. Third operation, buttress plate with a thin plain implant. I used 2 fibula plate to buttress the tibia medial and the anterior side with a mini multiple incision. You can see the incision for anterior plate, incision for medial side plate over there. This one, that just for screw, yes. This is anterior plate. This is medial side plate. 2 plates are pivot plate. So you can see this one. Okay, this is also Fibular plate, also this one. Okay, several days later, you can see the wound medial side and lateral side, posterior side, medial side, open wound over here, lateral side. After third operation, the patient developed cellulitis and subcutaneous infection and post-discharge. So I performed treatment with antibiotics, rifampin 300 milligram BID or 600 milligram QD, and trimethoprim and sulfamethoxazole, and continuous squeezing and dressing. This rifampin is very good options to treat the infection like this. Usually the gram-positive and infection, also rifampin can treat MRSA, so I usually use the rifampin to treat like this infection. 1 or 2 weeks later, the wound is really cleared and is infection subside and cured like this. And a small stitch, and after stitch out you can see the this is after operation. The initial one is mid thumb, and this final one, the middle side. Yes, this is middle side open wound, and this is previous cochlear fracture. This was a lateral incision like this, and posterior incision like that. So I'll show you the final x-ray like this. It is open fracture, open comminuted fracture, and 4 implant, and another 2 cannula screws like this. It's AP view and the side view. Thank you.